Hi everyone, Amber Middleton and Kristen Fawcett here. We are going to talk about the Bakri postpartum balloon. The most common cause of PPH is uterine atony. We see that so many times. So this balloon helps to prevent postpartum hemorrhage. It works because of a gentle traction. You can see a picture here in which the balloon creates a tamponade effect. The balloon itself is 100% silicone. There is no latex at all. So once you open it, you are going to see a tray like this. It comes with IV tubing on the top here, and you can move this tray out of the way. And then we have our Bakri balloon itself. It comes with a syringe, and it comes with a stopcock. So what you'll do is prime your IV tubing with any type of sterile fluid. It can be water, it can be LR, it can be saline, whatever you have, as long as it's sterile. The max volume that you want to fill with is 500 cc's. Usually we do around 300, could be a little more, a little less, but max is 500. A couple of quick notes: an RN can remove the Bakri balloon, but an MD has to remove the packing. So if they use packing, which they do not have to, the doctor has to be present to remove that. You also want to be sure, if they use packing, to document. And if a doctor removes it, document that. Before you place a Bakri balloon, the doctor should make sure there are no retained products, no open lacerations, and they should place the whole balloon, you'll see here, into the cervical os. So you want the whole balloon inside the uterus. They should determine the uterine volume before they place it, and the company actually recommends that you use ultrasound. You can do a vaginal placement or an abdominal placement. Typically what we see is vaginal, and if that's the case, they are going to just kind of use this tip. It's like a Foley tip. Insert it into the vagina, into the cervical os, and into the uterus, making sure that the whole thing is in. If they do it during a C-section, what they'll do, you'll open the whole kit onto the field, and the surgeon will actually put this end in first. They will insert it through the cervix into the vagina, and they will actually have a helper down at the foot of the bed. The patient will probably be in stirrups, and they will pull this end through so that this is all that remains in the uterus. You always want to also have a Foley catheter for urinary output monitoring. And then I'm going to show you also how to fill it, which is the big thing that we sometimes mess up on because we don't do this a whole lot. So what you're going to do is you're going to take the tubing that was here. You are going to prime it. And the stopcock comes with a little red end. It looks just like this. And you're going to insert it to this end. Okay, so they fit together just like that. So prime your tubing. Then you are going to hook the syringe to the only side that it will go to. You see how this won't fit? It will only fit on this side. So put that in there. Then the only one you have left is this end, and you are going to put it in the only place it will go. Okay, so the balloon is in place. Doctor's ready for you to blow up the balloon. So all you have to do, this stopcock has a two-way valve. So you're gonna pull back on this. There's a two-way valve in the stopcock that prevents it from leaking anywhere else. And you're just gonna push the fluid in. And every syringe will give you 50 cc's of fluid. So that's 50. You're gonna pull back 50 more. And notice I'm not having to move the stopcock at all. So pull back and push in. Super easy. Okay. Now, say you've got your 300 cc's in and you're all done. Doctor says, that's good, let's stop. what you're gonna definitely want to do is turn your stopcock now, because when you unhook, then the fluid won't come back out. If you forget, you'll remember real quick, because this is what's gonna happen. You're gonna be like, oh crap. So you definitely wanna have that turned. And then you're done with your setup over here.
After you insert the fluid and turn the stopcock, you're gonna wanna grab a Foley bag and attach that to the drainage end of the Bakri balloon to catch any blood that might drain out of the uterus.
The balloon itself can stay in for up to 24 hours. It can be less. And whenever the doctor says it's okay to take it out, what you're gonna do is get a separate syringe. If they want you to take out a little bit at a time, you're gonna take a new syringe. You are going to hook it up here. Then when you open the stopcock, you can pull 50 cc's out at a time. Say they want you to do 50 cc's every couple hours or 100 cc's every couple hours. That's how you would do that, and you would have an exact amount. Now, research has been done that says there's no evidence of it being better if you do a little bit at a time. So if the doctor wants you to remove all the fluid at the same time, you don't even need a syringe. Just open that stopcock just like we did accidentally earlier. Just let it all drain out. So you want to make sure after the balloon is placed that it is pulled relatively tightly against the cervical os. That way that balloon is really tamponading like that you see there. You don't want to do a fundal massage while you have one of these in place, but you do want to assess your fundal height. So just make sure you know where your uterus is.
If you're in the OR when your physician requests a Bakri balloon, you're going to go to the bottom left corner of the OR cabinet, which is where your Bakri is going to be stored. If for some reason you need another Bakri balloon when you're back in the OR, just go back to the OR supply room and it's back by all the sutures. If you're back in the PACU, you're going to come to the back left corner here where all the carts are. This is where your hemorrhage cart is, so you're going to pull your hemorrhage cart and your Bakri balloon is sitting on the top. If you're on labor and delivery, you're going to come up here beside the med room and the nutrition room, grab your cart, and your Bakri balloon is going to be on top of your cart.